Hey everybody, and welcome to AiArthritis Voices 360. This is the official talk show for the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AiArthritis for short. My name is Leila P.L. Valete, and I am a person living with lupus and Sjögren's disease and the health education manager here at AiArthritis. Today is a special episode to report back on breaking research in the rheumatology community. Me and several members of our team were in Washington, D.C. this past week, attending the American College of Rheumatology, or ACR, Convergence. We attended several sessions and reported back on topics that we felt were important for patients to learn about. So please enjoy these 4 research updates.
Hi, everyone. This is Tiffany Westrich Robertson reporting to you live from the American College of Rheumatology Conference 2024. And I am a person living with non-radiographic axial spondyloarthritis. On this segment of the debrief, I'm going to focus on new therapies for our diseases, which are focusing primarily right now in lupus, but also in some diseases like myositis and systemic sclerosis as well, or scleroderma. But in this particular model, and the one I'm going to talk about today, they are both in lupus. And so if you're asking, why do they always start in lupus? Lupus is a very complex disease, one of the most, if not the most, in our group of couple dozen diseases. And so if they test in one of the most complex ones to begin with, it's easier to adapt as they start to move into other diseases. So don't be discouraged if you're like, why is it lupus? That's the reason why. So I'm going to cover 2 different types of cell therapies. That's the big hot topic at this ACR 2024. And these are different than our current biologics. These are using our own cells or donated cells, in some case from others. And you're going to hear about both of those situations today in my report, and then infused back in the body to deplete other cells, and they don't know the exact reason why it works, but it ends up putting most people into remission, in complete remission. So very different than the biologics, where we might do a trial and error, and then we might have some improvement, but we still could flare, that type of thing. So these are very cutting edge type of therapies early in the process, but exciting all the same. So the first one that I'm going to briefly talk about was presented by Bristol Myers Squibb, or BMS. And this one is specific to CAR-T, CAR-T. And essentially in these studies for lupus, they take your T cells, they draw them from your body, and then they go to a lab and they essentially modify these T cells, and they will infuse them back into your body. So it takes about 2 weeks before the reinfusion happens. And in the interim, they do a mild form of chemotherapy to then deplete your B cells, so that as this gets infused back into your body, there's no type of reaction. Everything is starting fresh, and it is a reset. That's a big word I kept hearing all through ACR2, was a reset, because of this new cell therapy. So once these patients have been treated, they are coming back with little to no disease activity, primarily 100% remission. They had some people from the cancer community there, because this started in cancer. Now it's moving to autoimmune. And the cancer patients who had lymphoma and went through this all are in complete remission 7 years later. And they said the C word used to stand for cancer. Now it stands for cure. So that's a word that we are also not familiar with in our communities. So the fact that these types of therapies are on the horizon is super hopeful. The second one, Deb and I met with a company called Artiva, and they are also working in cell therapy. And this one's just a little bit different. Focus also on lupus with or without nephritis, which means the kidney involvement. And their CAR T therapy is not pulled from your T cells from your body. Instead, it is donated through they said borrowed cells from donated umbilical cord blood. And so these therapies then are infused back into the body. And in this case, there is not that you don't have the mild chemotherapy part in it. So that part is removed. There's also not a hospitalization part of it. So this is more considered an outpatient type of situation. It is a deep B cell depletion. And the fact that they kept stressing the outpatient administration, and only if there were any potential side effects, complex patient, would anyone be hospitalized for observation. So this one is just another option that is being tested. There are current clinical trials on this, and we're getting more information about those. And so this is an exciting time for our diseases. Deb and I were talking earlier and thought, man, in 10, 15 years, this might be like the new treatment, the new wave of the future. The biggest obstacles, obviously, affordability. So these are going to be very expensive. We do not know how government healthcare systems, how we will gain access to those. But we know that if there's a one-time situation where you go into remission and you don't have to actually take these expensive other drugs all year round, that is a huge savings. But the other issue is we don't know how long these last. So we can say that, like, in the people who received these CAR T therapies 5 years ago, 3 years ago, 7 years ago, they're all still in remission, but we just don't know how long it's going to last. And so that's still to be determined. And that's going to really weigh heavily on how do you cost this out when we don't know if it's one time or 2 times in a lifetime or 10 times in a lifetime. So still a lot of research that has to be done in that respect, but really exciting times for all of us. So there you go. There is my update on cell therapy at ACR 2024.
Hi, everybody. This is Leila, Health Education Manager here at AiArthritis, and I am here to debrief day 2 of ACR 2024, or Sunday. So yesterday was Sunday. I'm recording this Monday morning because yesterday I had a bad day. I was very tired. And so I ended up going to one session, but I also ended up being able to read some abstracts and go to some of the abstract sessions. The abstract sessions are a long session in person. They're about an hour and a half, and they have little 15-minute segments of different abstracts that are under each different category that they have. So I was able to attend some of the weight loss, some of them that had weight loss in it, as well as information about pain. Okay, let me correct myself. It's not about weight loss. It's actually about obesity and how obesity can affect inflammation. And the prevalence of obesity in autoimmune diseases it's pretty significant. So in RA, they say about 14% patients are obese. In lupus, it's about 14%. And in psoriatic arthritis, it's about 20%. And so in psoriatic arthritis, they exhibit higher odds of developing. So obese individuals are more likely to develop psoriatic arthritis. And so that was a very interesting thing to learn. I had never heard anything like that before in terms of how likely you are to develop an autoimmune disease if you are obese. And I have been obese my whole life. I actually had weight loss surgery last year, the vertical sleeve gastrectomy, in order to help with my obesity. And even though I got weight loss surgery and did lose a good amount of weight, I'm still considered obese, and I will still be considered obese probably my whole life because of my BMI. And so it's very interesting to learn how obesity can affect these autoimmune diseases. And from this abstract, that's really what I learned was the prevalence of obesity in the autoimmune diseases that they studied. And they do have recommendations and actionable tips in order to help with obesity, discussing your weight with your providers, incorporating a balanced diet and exercise, things that we all know about and do try to incorporate in our lifestyle, although it doesn't account for the recommendations that they give don't account for the symptoms that we may be experiencing and that may prevent us from, exercising on a daily basis or as much as we'd like to, or the motivation for us to be able to exercise and be able to cook for ourselves healthy food and things like that. Yeah, hopefully because they know this now that these patients are more likely to have these autoimmune diseases and have obesity, then maybe there will be a next step afterwards on tailoring specific programs for obesity for those who have autoimmune disease. For me, my autoimmune disease or my lupus was not considered in any of my weight loss programs. I technically look like a unsuccessful weight loss surgery patient because of the outcomes that came from my surgery. It wasn't enough of my body weight to be considered successful in the amount of time that they deem. But also what we need to know is that in order for your body to lose weight, you have to be healthy. In order to be able to lose the weight, your body has to feel like it's in an equilibrium, in homeostasis of being at a good place, like not your immune system is not super overactive and there's not infections going on and things like that. Because in the beginning, after I got my weight loss surgery, I had a bunch of UTIs, and those UTIs I felt kept me from losing as much weight as I should have in the beginning because my body just was freaking out. I just had this surgery and I'm having an infection. It's trying to, balance out and figure out what's wrong before it is allowing you to shed the weight. And so that's just one thing, is that in order to even be able to change anything about weight, appearance, anything like that, you have to be healthier overall in order to even have your body allow you to do that. So of course, no matter what, even if it's not to lose weight, exercise is always so good to help with the joints, to help with movement and just overall wellness. But in order to really lose weight and lose weight hardcore, you have to be healthy. And so I just want to say that with obesity and with weight loss and how much in America we do try to push weight loss, and there's a lot of that conversation going on now, just remember that your body is fighting its own fight. And it can be a lot harder for us to lose the weight. So I just wanted to make sure to give that validation to everybody, because I know that weight is something that a lot of people with our conditions struggle with. Another one of the abstracts that I went to was about chronic pain. And it was about pain disability reduction. So participants who who completed this study, they reported a significant decrease in pain-related disability. And that's amazing. Pain can debilitate a lot of us in a lot of ways. And so this was mainly for older adults, and they practiced a self-management program and provided tools and strategies to help manage chronic pain. The program, it offered varying benefits on individual factors such as age and socioeconomic status. So they tried to do their best to meet the patients where they were and what they could accommodate for. And so I actually pulled up this program is from Stanford, and it's called the Chronic Pain Self-Management Program. And these are the different tips that they have developed after going through this program with this first set of cohort. And so these are the tips. 1, determine how you spend your time. Keep a diary of how long it takes you to do activities and how long you need to rest for in order to recover. 2, make a schedule. Develop an activity schedule that includes rest breaks and stick to your schedule. 3, be time-oriented, not pain-oriented. Knowing how long you can do an activity before your pain gets worse means you can schedule specific activities for a certain number of minutes before taking rest for a specified period of time.
And this keeps you not in pain, but in control. Rest before your pain starts to get worse, because so many times we want to complete activities and push through pain to keep schedule, but stop and make sure to take a rest. I needed to learn that yesterday when I was not feeling well after pushing myself so hard the past week to prepare for the conference. 5, incorporate change into your activity routine. A change may be just as good as rest. If you're in a situation where you can't take a rest break, alternative activities frequently, changing body position, stretching, or going for a walk. Use a timer to signal breaks. Me and Deb were just talking to Tiffany about this morning, and that we try to set timers for activities that we're doing. So that in case, 1, we need to keep time, or 2, if you know that you can only do that activity for a certain amount of time before you lose focus or before you start to be in pain, that's really important to keep yourself going. 7, break tasks into smaller, more manageable pieces. 8, avoid rushing. Slow down, plan ahead, and because rushing can increase your stress, which therefore can increase inflammation and pain. So it's a really unfortunate phenomenon and conundrum that happens. 9, don't overschedule activities. Work on developing realistic expectations for yourself. I still really have to work on that. I always can think that I can do more than I can. And so I end up under delivering of what I would wish I could. So I need to make more realistic expectations for myself and prioritize your activities. Some days you may not be able to get to everything. Determine the most important thing you want to accomplish in that day and then work on that. And yeah, I think that those are some amazing tips to be able to go by. And this is what the chronic pain self-management program was based off of that they presented in this abstract. And let me actually read the titles of these abstracts so that if you wanted to look back, you could. The chronic pain is called Impact of the Stanford University Chronic Pain Self-Management Education Program on Pain Severity, Pain Self-Efficacy, and Pain Disability in a population with a high prevalence of arthritis. Speaking of older individuals. And so let's see. Okay. And then the other one that I spoke of is Obesity and the Risk of Autoimmune Diseases, Insights from the National Inpatient Sample. So those are the 2 abstracts that I wanted to report back on because I thought would be very interesting to our patient population that is watching this. And lastly, I did go to a lupus nephritis care session. It was called Test Your Knowledge. So basically the whole session was very interesting. It was going through a case study of the patient that the researcher had in real life. And so it was like a spectrum of time and different decisions that were being made in this patient's life and how the treatment that they were receiving was tailored to those different decisions that were being made during that time of life, during diagnosis. Or again, it's a spectrum of the patient journey. During diagnosis, your decision-making on treatment can be totally different than maybe 3, 4, 5 years down the line. And basically they went through the different times when they took kidney biopsies to really see how bad the lupus nephritis was in that moment. They talked about the different treatment options that there could be and that there's no wrong answer in what they provided, but just showing that there's a variance in how every single individual rheumatologist would treat specific cases in general. And so there's always going to be different combinations of medications that they think may work well together and things like that. So it was really cool to see how the different rheumatologists in the room would think, because they were asking to raise your hand for which different treatment option you would go with. And the researcher basically said that a strategy on getting very detailed insight on what's actually going on in the body is doing a kidney biopsy. And although kidney biopsies can be very invasive, they are the only way to really know how someone's lupus nephritis is going and at what stage it's in. And she does recommend to do them often or whenever treatment changes are being discussed. And so that was a very interesting session to go to, just to see how all the different rheumatologists differ in their options that they would pick, and also comparing the options that were up there to the shared decisions that I've made with my providers, especially around family planning, on preference, whether you like injections or infusions or pills, or the amount of pills, things like that. It's really amazing to see that there are a lot of different options for the medications out there and the different combinations that you can do. I also saw some information about other sessions that talked about the alternatives to kidney biopsies. And so I do want to report back on that and a little bit more about some of the lupus abstracts. And I will do that for my video for today. And so thank you so much for watching. This is day 2 of Go With Us to ACR 2024. Today is going to be our last day of actually going to the conference. So today, Monday. And I'm excited to report back and give you my feedback from whatever happens today. I have to go and get ready now, but thank you so much for listening to my debrief. And if you have any questions, feel free to email us back about any of these debriefs that we have. You can tag us on social media, message us on social media if you have any questions, or if you are in our Slack elevated experience, you have access to us right there. Alrighty, talk to you all later. Bye.
Hello, everyone. My name is Cristina Montoya. I'm a dietitian and a person living with Sjogren's disease and rheumatoid arthritis. Today, I'm wearing my patient's hat to share with you a few highlights from the session I attended on day 2 on the novel imaging and therapeutics in Sjogren's syndrome. This is part of the Go With Us to Conferences program led by AiArthritis, short for International Foundation Autoimmune and Autoinflammatory Arthritis. So let's start with Dr. Alan Byrne. Dr. Bear is the director of the Jerome L. Green Sjogren's Disease Center at Johns Hopkins University School of Medicine. He presented on the challenges for disease-modifying therapy in Sjogren's disease. So I just wanted to clarify that you might see the name Sjogren syndrome, but remember that Sjogren's, the name was just changed, officially changed this year. So when these sessions were submitted in 2023, it was still considered Sjogren syndrome. So please don't get upset. Now, this session's objective was to understand the fundamental tension between Sjogren's disease modification and symptom relief in Sjogren's clinical trial designs. Dr. Bear shared how Sjogren's disease has high morbidity and a high burden to the patient that included not only the sicca symptoms of dry eyes, nose, mouth, and skin, and everywhere else, but also fatigue, morning stiffness, trouble sleeping, muscle and joint pain, and brain fog. He highlighted what patients want from a new systemic treatment. Patients want a better management of day-to-day symptoms like fatigue, muscle, joint pain, dryness, neuropathy, and dysautonomia. Patients want to reduce Sjogren's flare-ups. They want to reduce the risk of long-term concerns like extreme dryness or lymphoma, and stop medications like prednisone and other chronic medications. But what are the challenges on developing medications that can modify the disease? The main problem is that there is a poor correlation between the disease activity, which is measured by the SDAI, or what is short for Euler-Sjogren Syndrome Disease Activity Index, and the Symptom Burden Index that is measured by the ESPRI, which is the Euler-Sjogren Syndrome Patient Reported Index. There's also challenges in monitor the salivary and gland dysfunction when it's already too advanced when the patient is diagnosed, and it may not be reversible. And another challenge will be that the disease progression is very slow compared to other rheumatic diseases. So that poses a challenge when they're doing clinical trials, because maybe the time is just not enough to see the positive side effects. Dr. Baer also stated that unfortunately, the scores used to measure the disease activity do not fully capture the disease systemic involvement. So according to the ESSDAI, 15% of patients will develop severe systemic disease, but up to 50% of patients can develop systemic manifestations in other autoimmune diseases over 10 to 20 years. So you see, it varies. And that also interferes with early diagnosis and detection of the disease. The current limitation of clinical trials is that they target select populations. They do not include seronegative patients, or at least not for now. And they identify that there is a robust placebo effect. So they need to decipher whether is the effect from the medication or is the placebo effect. In some studies, although there is a statistically significant response, it is not always reflected on how the patients feel, meaning that the biologic effects do not translate into the clinical effects. He said that it's possible that patients need that extra time in those trials for the effect to be seen. So better outcomes could be obtained if there were better tools to exclude the non-autoimmune Zika, if there were tools to predict the evolution of Sjogren's with those with Zika and or anti-SSA positivity, and a better understanding of the symptom etiology. As a patient, I felt validated by Dr. Baer because he explained the barriers and limitations, and he also shared what are the patient's expectations from these clinical trials. So I truly appreciated this session. The next one was on the novel imaging to diagnose Sjogren syndrome, cutting-edge techniques. So this one was by Dr. Hosevar from Slovenia. And just like I said on the title, it says Sjogren syndrome, but then she right from the get-go, she said, I'm going to talk about Sjogren's disease. So that was very validating as well. This one was a little bit over my head because they were just basically talking about advancing and utilizing the ultrasound of salivary glands to diagnose and potentially evaluate the progression of the disease. Because she indicated that to this date, we don't have 100% sensitivity diagnostic test or diagnostic criteria for Sjogren's, which delays the diagnosis and treatment. As we all know, basically the doctors utilize the classification criteria, which is not the same as a diagnosis criteria because technically it doesn't exist yet. So it takes a full expert, a clinician's expertise to see the patients holistically beyond the Zika symptoms. She explained that using the ultrasound of the salivary glands and also MRI in cyanidoscopy, so basically it's just an endoscopy that goes directly into the salivary gland, could potentially determine or detect the Sjogren's disease a little bit earlier. But despite these potential imaging techniques for diagnosing Sjogren, to make the Sjogren's diagnosis, there must be a comprehensive clinical, histological, and imaging test to confirm the diagnosis, and not just to rely on the testing of the salivary glands, especially when the results are not conclusive. Remember that a lot of patients, because the disease progresses so slowly, they do not present the histological changes in the salivary glands. Unfortunately, as a patient, I saw that the new testing, again, is very focused on the salivary glands and not on the systemic involvement of the disease. And the last session was presented by Dr. George Bruin from the Netherlands. And it's quite funny. It was also very interesting because he walked us through all the clinical trials that have been conducted on Sjogren's for the past 20 years, I will say. And what I could determine is basically all of them had failed, that they moving to like phase 2. And then when basically says there's no significant changes on symptom burden or biological changes, There was someone in the audience with Dr. Bookman. He's our Sjogren's expert in Canada. And he asked, and they specifically said, maybe we're just not giving enough time to these trials and enough time to the patients to feel the real effects. They also talked about that perhaps we are still identifying part of the immune cells that they need to target in Sjogren's. So currently there are over 20 clinical trials on patients with Sjogren's, which is really revolutionary and it's very neat. 3 are currently in phase 3, meaning that now they're expanding the results to a larger population. The good news is that pharmaceutical companies prioritize drugs for autoimmune diseases. This means that, but still we need to be cautiously optimistic, really indicated. Let's not promise anything to the patients yet. We have to see the results of these clinical trials. My takeaway from this session is that at least one clinical trial is showing some early positive results and moving to phase 3. But overall, I saw more abstracts and scientific sessions on Sjogren's than any other years. And I couldn't even enter one of the sessions on Saturday because there was an overflow of people wanting to learn more about Sjogren's. So I can see the light when it comes to Sjogren's disease. So I hope this was helpful for you, and I'll give you another update tonight or tomorrow. Bye.
Hi there, everybody. Today is the end of day 2, and we've seen lots and lots of stuff. You can see we're back at our Airbnb, and I'm already in comfy clothes. I'm wearing red because of AiArthritis colors. So I just wanted to kind of preface that for everybody. So the debrief I'm doing today is specifically on menopause and rheumatic diseases. So you're going to see me looking over to the left here. Oh, my left. I don't know what's going to look like for you guys. But my computer's sitting over here with slides that I wanted to specifically talk about. So you can take a peek and just, again, apologize for my eye contact being over there, but it's the best way so you guys can hear everything that I learned today. So today, the first part of the menopause section had 2 parts. So the first one was transitioning through menopause, implications for patients with RMDs, and the speaker was Sharon Parrish. She's from Weill Cornell Medical College. Not sure where that is, but she did a fabulous job. So the learning objectives of this particular piece was recognizing common perimenopause and menopause symptoms in patients with rheumatic diseases, and including those which that have a little bit of a differential. So they speak more about the flares that we have and things like that. And also talking about the psychological changes that we all have during that time, because there are many. I've been through it, so I know. Then we move on to the symptoms of menopause. The typical things that we always talk about are changes in our menstrual cycle. There's the hot flashes, sleep problems, big mood disturbances, and depression that can go with it. Vaginal health and sexuality that can have some issues, bladder control and infections leading to more incontinence and things like that, weight gain, and joint pain, of course. One thing she's focused in on are called vasomotor symptoms, and it affects 50 to 82% of women at some point during their menopause transition. And it talked about ethnic and racial differences in the Black, Hispanic, white, Chinese, and Japanese women. When it talked about hot flashes, what occurred during the day, there's the night sweats, which happen at night. Common sense as far as that goes. And it talked about sometimes you can even be sweating so much that all of a sudden you get the chills because air is hitting you and you're soaking wet, your hair's wet and things like that. So you can actually even get chills that are associated with that. Heart palpitations, and let's see, just different things. So it talked about also the menopausal excuse me, I'm tired, symptoms and the burden of those other symptoms. So the primary ones that we talked about were the primary one that was number one issue was sleep. Next one was self-care. Next one was work. And the next one was your mood and your emotions being all over the place. And they also talked about hot flashes being another one of the number one symptoms that had a huge burden on folks. Premature menopause. So that is talking about, they actually did a study that talked about the primary ovarian insufficiency before the age of 40. So that's very young for menopause to actually start for any woman. And it talked about just all the different things that can happen with that, with adverse long-term health consequences, coronary heart disease, osteoporosis, mood disorders, and elevated risk of genital urinary system. So all of the urinary tract infections that we can get, as well as dryness and things like that. So that was definitely talked about, and just it made me feel better because, again, I've been through so much of this that I wish I would have known this information ahead of time. Let's see. They talked about risk factors for a lot of these symptoms that we were talking about: obesity, smoking, low socioeconomic position, high fat and high sugar diets. None of the things we want to talk about, right? Medical comorbidities, etc. So menopause and lupus. They talked about the mean age that menopause tends to happen is 46 years. So roughly into your 46th birthday. And they said it happens, there tends to be a little bit more of a risk of early menopause in lupus patients. There was, let's see, they also said that after menopause, that your symptoms for lupus may improve. So that's a highlight. So again, nobody wants to go through this, but we all have to pick and choose what we're looking forward to. Let's see, menopause and rheumatoid arthritis. They do say that there tends to be a lot of inconclusive data, so they're not exactly sure at this point as far as the effect on and the severity and onset. They also mentioned that there's not a lot of studies on menopause. And definitely when I was going through it, my symptoms increased and were exacerbated significantly. Not that's going to happen to everybody, but that's my own experience. And I'm only 55. Let's see. Extreme excess bone loss is seen in RA, and increased osteoporosis that they talked about. Managing the symptoms. So it's funny. They talked about addressing the hot flashes with hormone and lifestyle interventions, diet, exercise, supplements. It depends on if it's counterintuitive for you to actually go on to estrogen. They talked about sleep disturbances and all of those kind of things. And also just really the sexual function. So having sex gets more difficult. So there are things you can actually do, which I'll get into, that can actually help your symptoms. So comprehensive care so after menopause is finished, is lifestyle organization, dealing with your nutrition, taking a good look, physical exercising, reducing alcohol consumption, and not smoking. Let's see. There are some non-hormonal therapies to deal with some of these symptoms. And they talked about I might say this wrong, paroxetine, which is a low dose mesylate salt, which is FDA approved. There's a kinin B antagonist, which also is FDA approved and should help with symptoms. Other off-label things are like serotonin and gabapentin, which some of you might have heard of. And as far as dealing with some of the issues with the urogenital areas, using moisturizers, lubricant, and be alert as far as if you're not having sex quite so often, then you might want to lean more on these type of things. They talked about using actual lidocaine in your vagina so it doesn't hurt so bad because of the other things that we were talking about. Look into actual different positions so it actually is more comfortable for the woman. And also talking about go to additional counseling for things like talking to counseling about your fatigue and things that really are bothering you and having really good communication with your doctor. The key points, again, is some of the things I talked about, all the different indications and the pain, sleep difficulties, and things like that. For lupus patients, they may be influenced by your menopause status. So whether you're feeling better or not feeling so good, there's definite things that lead to that. The osteoporosis in rheumatic diseases and bone fragility. So definitely keep an eye on all of those things. Second section was related to menopause, treatment options, and safety considerations. And it was a doctor from Weill Cornell Medicine. And she talked a lot about the risk assessment of cardiovascular disease and breast cancer. So depending on your breast health and cancer status, if there's anything going on, they definitely have done some studies leading to just looking into women that are at risk for cardiovascular disease or breast cancer. And it was definitely conclusive that you just need to follow what your doctor's telling you. Let's see. There was a piece that was done on 351 menopausal patients that either had inactive disease or active disease. And it talked about, this is for lupus patients, and looking into the symptoms and using estrogen versus a medication. And it definitely showed that the group with the hormone therapy did better. So if you're able to take hormones, that actually helped in this situation. Let's see, this one. And this last study was specific to short-term hormone therapy, and it definitely was associated with helping decrease the flares in people with the rheumatic diseases, and this is specific to lupus and RA. So those are the things and some of the takeaways I had. Again, I've been through most of this, so I totally understand that it is a really significant topic for us. And again, me being 55, I had a hysterectomy, had my ovaries left, then had one ovary taken out, and because it was very cystic and it was problematic. So then after that, I went into horrible hot flashes, at least 20 a day that were like hair soaking, clothes soaking, and I had to change my clothes at least 5 times a day. So not a fun period to go through, but with hormone therapy for myself, it has actually helped significantly and really held off a lot of the other symptoms that they were talking about. So definitely happy to be here and ask questions if you haven't.
Thank you for joining us today for episode 104 of AiArthritis Voices 360 talk show. If you are interested in learning more about our Go With Us to Conferences program or watching our content from previous scientific conferences, you can visit www.aiarthritis.org/conferences. And if you love programs like our talk show and Go With Us, please show your support at www.aiarthritis.org/donate. These programs are only able to keep running with your support. Thank you all.